Chapter 20: Sexual Dysfunction, Gender Dysphoria, and Paraphilic Disorders. Allison is an attractive biracial post-college grad who's just starting a career she really enjoys as part of a Chicago sketch comedy team. She describes her low sexual excitation saying, "I'd like to be married someday. I want love. I like cuddling, but I was never tempted to have sex. I was always just, not interested. My boyfriend in high school accused me of being gay, but then why don't I fantasize about kissing a girl either?" she smiles. "Anyway, what do you think? Am I normal?" By its definition, a sexual dysfunction is just a disturbance of the desire, excitement, or orgasm phases of the sexual response cycle, or pain during sexual penetration. There are many different classes of sexual dysfunction, everything from male hypoactive sexual desire disorders, female sexual interest or arousal disorder, erectile disorder, female orgasmic disorder, delayed ejaculation, premature ejaculation, and genitopelvic pain/penetration disorder. There is also asexuality, which is not necessarily a disorder, it's possibly a form of sexual orientation. Female sexual interest or arousal disorder is an emotional distress caused by absent or reduced interest in sexual fantasies, sexual activity, pleasure, and arousal, and symptoms must be present for at least 6 months. Whereas male hypoactive sexual desire disorder, there is deficiencies or absence of sexual fantasies or desire for sexual activity, and these symptoms must again be present for a minimum of 6 months. First would be erectile disorder, also called erectile dysfunction or impotence, and this is difficulty obtaining and maintaining an erection sufficient for sexual activity. It must occur on 75% of sexual occasions, must occur for at least 6 months, and may be lifelong or acquired. Next would be female orgasmic disorder. This is also called inhibited female orgasm or anorgasmia. It's a recurrent or persistent inhibition of female orgasm after a normal sexual excitement phase. It must occur for at least 6 months and must occur during most sexual encounters. Delayed ejaculation, formerly referred to as male orgasmic disorder, inhibited orgasm, or retarded ejaculation, and in this condition a man achieves ejaculation only with great difficulty. Symptoms persist for at least 6 months and could again be lifelong or acquired. Not to be confused with premature ejaculation. In this, the male persistently or recurrently achieves orgasm and ejaculation before he wishes to, and the symptoms must be present for at least 6 months. Next would be genitopelvic pain or penetration disorder, and this is discomfort or pain that interferes with penetration during sexual activity. It may also be elicited during normal gynecological examination, and a fear of recurrence compounds the problem by increasing anxiety and muscle tension. This group of disorders previously diagnosed in the psychiatric community include a problem called dyspareunia, which referred to pelvic and/or vaginal pain during or after intercourse. It also included vaginismus, which referred to an involuntary constriction response of the muscles within the vagina. Researchers believed that the distinction between the two disorders is too blurry and subsequently combined them into this single disorder. Other sexual dysfunctions could be sexual dysfunction due to a general medical condition, such as cardiovascular disease, neurological, or endocrine diseases. Substance-induced sexual dysfunction could be a result of alcohol, amphetamines, or other substances. Or sexual dysfunction not elsewhere classified is a result of a presentation not quite strong enough to meet the criteria for a disorder, but still disturbing to the patient. There are many factors that could lead to this condition, everything from endocrine, vascular, neurological, genital, or systemic issues. They could also be a result of cognitive factors such as misinformation, ignorance, anxiety, poor communication, or unacknowledged or unidentified sexual orientation. The application of the nursing process. There are many patient cues that may indicate sexuality concerns, such as nonverbal behaviors like discomfort, blushing, signs of anxiety, or overt inappropriate sexual behavior. There could also be verbal behavior such as inappropriate sexual comments or jokes, open concerns about partner relationships, expressed concern over diminished sexuality or sexual performance, and expressed concern over sexual impact of medications or comorbidities. There's many causes of discomfort on the nurse's part as well, such as poor training, inexperience, inadequate time, beliefs that sexual history is not important, and the fear of causing embarrassment. These concerns could also be related to age and gender differences. It will take time as you become a nurse where you're just you're very comfortable talking about things that most people wouldn't be. And that just takes practice, that takes experience. Some helpful considerations are remembering your role in maintaining a professional tone and approach, and remembering that assessing sexuality is a part of holistic nursing care. Under what circumstances do you imagine you personally would feel the greatest challenge in discussing a patient's sexuality problems? And that is probably a thing you should think about, thing you should be aware of before going into the bedside, before assessing these conditions. Our nursing diagnoses are going to be impaired sexual functioning. This is a change in sexual function during sexual response phases of desire, excitation, and/or orgasm, and viewed as unsatisfying or inadequate by the patient. Other nursing diagnoses: relationship problems, situational or chronic low self-esteem, negative self-image, or lack of knowledge about sexual behavior. When assessing these issues, you want to make sure your setting is private and without distraction. Keep note taking to a minimum, and interview free from personal biases and judgmental attitudes. Keep good eye contact, relaxed posture, and a friendly facial expression. Help to facilitate the patient's comfort, make them comfortable, and build up a rapport to hopefully get the patient to open up. For outcomes classification, planning outcomes and treatment may occur as part of care or a coexisting disorder, identifying that underlying issue. There could be pharmacological treatments. There could also be psychological therapies, behavioral therapy, systematic desensitization. It's going to be very dependent on what the underlying cause of the dysfunction is. Gender dysphoria, a topic that's coming up more and more these days. And gender identity. This is a sense of maleness or femaleness, not usually established until a child is 3 years old. Gender dysphoria is that feeling of unease about either gender. While biological factors are not thought to cause this problem, they are believed to influence its development. Hormones play a role in decreased levels of testosterone in males and increased levels in women, and are associated with that gender dysphoria. There is some evidence to suggest a genetic link as well. There could also be cognitive factors. Learning theorists suggest the absence of same-sex role models may contribute to gender dysphoria. Our nursing diagnoses would be gender identity disturbance, and with an outcome of helping them seek social supports, using healthy coping behaviors to resolve sexual identity issues, and acknowledging and accepting sexual identity. For treatments, in adolescence is used to delay puberty to allow more time for exploration, and in adults used to alter their chemistry towards their preferred gender. There can also be sexual reassignment surgeries and many other treatments available out there. For psychological therapies, there's a lack of consensus on the best approach, especially in children. We need to optimize the child's psychological adjustment and well-being, include family-directed therapy as well. For adolescents and adults, it's going to be individual and family therapy and working on their coping skills to deal with issues that may arise. Continuing with our case study, although Allison is keeping her sense of humor about it, she's concerned. She tells the clinic nurse, "I really feel confused about not only my sexuality in general, but even my ability to be a sexual being. I want love, I want romance, but sometimes I feel as if sex is a nuisance. Who wants to slow down for that when there are so many other things I want to do? Does that make sense? Am I crazy?" Our first audience response question: which statement by Allison would suggest asexuality? A. My family sent me to a so-called conversion therapist when I was a teenager, and all it did was make me hate my own existence as a sexual being, and I just don't think I'm gay. B. My last boyfriend raped me on a regular basis, saying not wanting sex meant I was gay, and he'd rip any gayness right out of me. Yeah, that worked. C. I can't even figure out whether I'm bisexual or not because I don't really have much interest or time for exploring sex with either men or women. Or D. I take a lot of drugs. I mean, some for allergies, but other drugs too, you know? And the answer here is C. Asexuality. It's a distinct form of sexual orientation rather than a disorder, and asexual people may have an interest in some contact, but no interest in sex. The nurse and physician conclude that Allison is most likely asexual than suffering from a sexual dysfunction. More than desiring to alter any phase of her sexual response cycle, her greatest concern has been whether or not it's okay or normal that she has no interest in sex. She has no physical symptoms that would indicate sexual dysfunction, and no distress over her lack of sexual activity. Therefore, she can be reassured that it is normal for some individuals to simply be asexual. Paraphilic disorders. These are acts or sexual stimuli that are outside of what society considers normal, but are required for some individuals to experience desire or arousal or orgasm, and these symptoms may last at least 6 months. Many of the people involved in non-standard sexual practices find no need for therapy because their sexual activities are carried out with consenting adults, and they're neither illegal nor physically or emotionally harmful to either them or their partners. Exhibitionist disorder. This is an intentional display of genitals in public. Fetishistic disorder. This is sexual focus on objects intimately associated with the human body. And frauderistic disorder. This is rubbing or touching a non-consenting person. Other paraphilic disorders are pedophilic disorder, prominently or exclusive interest towards children. Sexual sadism disorder. This is sexual satisfaction from the physical or psychological suffering of the victim. And sexual masochism disorder. This is sexual satisfaction by being humiliated, beaten, bound, or otherwise made to suffer. Transvestic disorder. This is sexual satisfying by dressing in the clothing of the opposite gender. And voyeuristic disorder. This is seeking sexual arousal through viewing, usually secretly, other people in intimate situations. Other sexual disorders not specified: scatologic disorders, necrophiliac disorder, zoophilic disorder. There's a lot of different disorders out there. There are a lot of different factors that go into a person's sexuality, both biological, cognitive, and each individual person, each individual condition is going to have a lot of different factors compounding to make them what they are. Other reflection and self-assessment. Some nurses will find it challenging to work without bias with a patient who struggles with a paraphilic disorder. Reflect, journal. Remember, you are the nurse at the bedside. You're going to get very comfortable with experience talking about anything. It takes a little bit of practice. You really need to just remember, you are the professional at the bedside. Other assessment guidelines. Assess potential for self-harm or harm to others. Differentiate between victims and active agents. Focus on assessment of the presenting problem, and elicit the patient's perception of the impact of this disorder on both themselves and their families. Again, that risk for suicide, risk for violence, impaired impulse control, and problematic sexual behavior would be some of our nursing diagnoses for these conditions. And our outcomes are aimed at reversing or attenuating the nursing diagnosis, and focus on safety and crisis intervention. We really want to focus on patient education, prioritizing safety of both themselves and others, reducing or eliminating risky behaviors that may result in discomfort or shame, and improving their interpersonal relationships. There's going to be a wide variety of pharmacotherapy we could go into. Antidepressants may be prescribed for paraphilic disorders. Though medication is not used independently without other interventions, it's always going to be some combination of both medication and cognitive behavioral therapy or other psychological therapies. And wrapping up with our last audience response question. In 2012, former Penn State assistant coach Jerry Sandusky was convicted of 48 charges associated with pedophilia and sentenced to life in prison. Do you believe he'll ever acknowledge guilt? That answer is B for our textbooks. That was a really difficult situation. There's a great HBO movie on Joe Paterno. I believe Al Pacino played Joe Paterno, and just the terrible effects and everything that fell out from that from Penn State, the university. But anyway, that's all we've got for this chapter. I'll see you in the next slides.